giving the trainees all those NICU secrets, teaching the families, bringing you physiology and the latest evidence in management of NICU babies. Just having fun with it. All right, everybody, welcome to the Instagram Live. And I wanted to do this because obviously we're celebrating several things and making awareness of several things for the month of October. And you guys actually chose to talk about bronchopulmonary, or you wanted me to talk about bronchopulmonary dysplasia. So I'm here to do that, BPD. So welcome. I see several people joining. So hello to everybody. So let's go ahead and hit the topic. Let's get straight to it. And I really, throughout the whole video or Instagram live today, we'll, make some pauses for you guys to jump in and ask questions. I want this to be, as interactive as you guys want it to be. So feel free. In a little bit, I'm going to go ahead and stop for questions, and you can go live. You can ask the questions on the actual comment section below. So let's go ahead and talk about bronchopulmonary dysplasia, or BPD. So what exactly is BPD? BPD is also known as basically chronic lung disease of the newborn. Chronic lung disease is kind of a big umbrella term. So BPD is more specific to the actual pathophysiology of the infant. What it is essentially a multifactorial disease. What does that mean? That means that there isn't one specific thing that causes bronchopulmonary dysplasia. It is really lots of different issues, lots of different effects, lots of different variables that are affecting the baby, causing disease. But the disease process is fairly similar. There used to be sort of the old BPD definition or new BPD, and let's talk about that. So old BPD used to be the sort of typical lung disease that you would see initially in premature babies before a lot of the therapies, and we'll talk about some of the therapies as we get later down the road. But the old BPD used to be, you don't have surfactant, you have a premature baby born, you have them intubated because they haven't seen surfactant, they have very stiff lungs, very difficult to open. And so you basically have to use a lot of pressure on that machine to keep the lungs open, or the lungs from collapsing. Well, that constant pressure, and every time we put in that rate of 30, 40, 50, whatever it is, it's really like Mike Tyson punching the lungs every single time. Unfortunately, it's a necessary evil, but that's where, again, we'll talk about this in the sort of preventive strategies, but that's where we have to be so consistent and so in tune with trying to minimize the amount of pressure, because every time we have a baby on the ventilator, we are damaging the lungs. So you can imagine, before we had some of the machines that we have, before we had surfactant, the pressures that were used were constantly causing a lot of damage, and that as well as the use of oxygen was really, the combination of that was causing a lot of chronic lung disease. And babies, if they survive, because before premature babies weren't surviving as much as they do, they would actually develop this bronchopulmonary dysplasia. That's the old definition of bronchopulmonary dysplasia, or not the old definition, but sort of the old BPD. Now, with a lot of the lung strategies that we have now, and again, I'll mention those in a little bit, but some of those strategies that we use now to be able to minimize that damage, it's now still causing, we still do see the bronchopulmonary dysplasia, or BPD, but we now see it sort of, if you will, a milder form, or sort of, now we see it less of the severe BPD that we would see. A lot of the horrible structural changes and damage that you would see on pathology in the lung, now you see a lot less of that severe BPD, but you see a different type. And now you see basically a BPD that's of a premature baby that's survived through the different strategies that we use, but that has survived, but still you have that damage that's happening into the lungs and that remodeling And that is sort of the new Bpd we see nowadays. Every now and then, you do have to use a lot of pressure. You do have to, unfortunately, to allow the baby to survive, you have to use so much pressure that you still see occasionally some of the babies that have the sort of the old Bpd per se. But most of the time now we see sort of the new Bpd as we're being a little bit gentler with how we do our ventilation. So that is essentially sort of the big picture of Bpd. If you look and if you want to kind of look at the anatomy and the physiology, and again, I don't want to get too crazy nerdy on this, but basically what the lung is trying to do, it's seeing all this damage, and the lung is actually trying to protect itself from its damage. And in doing so, it begins to create new cells, but there's so much inflammation, there's so much damage that's happening that unfortunately the lung produces the cells inappropriately. They're not very well formed, they're a little misshapen, they don't really have the same strength and the same way of doing things as if the cells haven't been damaged. They're not as organized, and this is something called remodeling. The body is trying to do what it can, and it's trying to, if you can imagine a wall that's been torn down, and the body's trying to put up the wall appropriately, but maybe there's some areas that are missing cement, maybe it's not really organized, the bricks are not put in the right pattern. So you are getting a wall in a sense, but it is not very structurally strong. You can really push on that, it falls apart, or there are holes everywhere. So it's trying. And this is where, again, you have that remodeling syndrome. And we're going to talk about, when we talk about strategies, we're going to talk about steroids. And a lot of people believe that steroids, and the steroids that we use for bronchopulmonary dysplasia and Bpd, is to actually bring down inflammation. And that's not exactly true. A lot of it's actually the steroids, we'll get to it, but actually work to decrease this remodeling. And again, we're going to talk more about the treatments and some of the things that we can do to mitigate or decrease at least the risk of Bpd. We'll talk about detail. I want to stop and just say hello. I got lots of people join me. Hello, everybody. We have my good friend Josh, the NICU nurse. We have Nicole as well. Katie, 3 little hearts. Hello. They're all saying hello. Sophia, I think she's in Spain, so that's pretty amazing. Thank you for joining. And we have a few questions, and I'll get to the questions. I have pregnancy information 999 is asking a question. We'll get to that in a little bit. I promise. I'm gonna be answering and stopping to answer a lot of these questions in a little bit. So hello to everybody who is joining. So thank you again. All right. So what are the actual definitions of bronchopulmonary dysplasia? So there essentially are 2 definitions, and historically the initial definition was if you are requiring oxygen by 28 days, you have Bpd. And we still sort of keep that in a certain way. When a baby is about to reach 28 days of life, we look at the oxygen level. If they're on it, we say, okay, the baby has Bpd. The most recent definition, though, now kind of reaches the oxygen use or use of ventilation of some kind at 36 weeks corrected gestational age. And that is more indicative because obviously there could be so many other variables, so many other things going on in premature babies' lives at 28 days where they may be requiring oxygen, but it has nothing to do necessarily with the fact that they're going to develop Bpd down the road. However, the new definitions, again, at 36 weeks corrected gestational age, say you have been on oxygen up at 28 days of life, you were on oxygen, and now there are you can actually look at the severity of Bpd through definition of mild, moderate, or severe Bpd. In the mild Bpd, you essentially have the definition of you had oxygen at 28 days, you no longer have oxygen now. The reason why it's still called Bpd, the reason why those babies are still termed as having Bpd, and we'll talk about this sort of down the road, they can still have problems down the road, even though you may not be leaving the hospital on oxygen, but there are certain things that happen within the cells that will actually still propagate and still kind of show up down the road. I'll talk about that after this topic. The second definition is moderate Bpd. And moderate Bpd says that you saw oxygen at 28 days, and now at 36 weeks corrected gestational age, you are seeing oxygen but at less than 30% FiO2, and you're on no device. Okay, so that you may be on some nasal but you're not on the CPAP, PPV, or high frequency. Obviously, if you're ventilated, that would be an obvious one. And then severe Bpd is, again, you saw oxygen at 28 days, you are now 36 weeks corrected gestational age, and you are either on a device giving positive pressure, so you are on CPAP, you're on PPV, obviously again ventilated, and you are on 30 or you are on 30% or above FiO2. Okay, and this gives you an indication of prognosis. It's not for billing, it's not for anything, but it gives you an idea of how severe the lungs are and how is this going to be a problem down the road, or even sometimes acutely, how bad and how much oxygen we're requiring right now at 36 weeks, maybe an indication that you may be looking at a future where the only way to be able to go home and survive is with a tracheostomy. I'm not going to really address the topic of tracheostomy. If somebody wants me to elaborate a little bit more on this topic, we can at the end. But that's essentially it for the definition. So, who actually gets Bpd? What's the risk factor for Bpd? And we all know this for the most part, but essentially is being premature. We know that being premature, again, your lungs were still developing. It doesn't matter how good we've become in medicine with interventions, with your incubator and so on and so forth. It's not the same as actually having Mother Nature and having mom being able to protect while you develop those lungs. And so prematurity is the most common reason for development of bronchopulmonary dysplasia. As I mentioned, you have this new Bpd where you could actually have a baby who has never been intubated, never actually had a breathing tube, and still develop Bpd. That idea of new Bpd. The other things you can see are infections. There are certain infections or certain organisms that have been associated with Bpd, like Mycoplasma or Urea plasma. In some centers, they actually test for this. Any baby that comes into their hospital, they're testing for these bugs. If they see them, they prophylactically treat them. We'll talk about that. That's somewhat controversial, but there is some association. But there are other infections. Just developing something like necrotizing enterocolitis, developing some type of pneumonia, damage to the lungs. Again, it's basically the body's trying to counteract that. It's trying to create appropriate cells because it's finding that it's been under attack, if you will, and unfortunately the cells that are created, they're remodeled inappropriately, as we've already talked about in the start of this Instagram live. And so that is another reason for getting that. Another thing is the long-term, or how long you are using mechanical ventilator. We know there's a very strong association with a breathing tube. If you've had a breathing tube, the longer you have it, the higher the risk of developing bronchopulmonary dysplasia. Is it the breathing tube in itself? Is it that plastic going into your trachea? Yeah, maybe, probably. I mean, again, it's a nidus of infection. Infections can get through that, but it really is an indication that you're needing mechanical ventilation, that you're needing pressure to be able to open up the lungs. You're putting, as I mentioned, you're damaging the lungs each time you're doing that. But many times, obviously, you wouldn't be able to survive without it. So it's an unfortunate necessary evil. But the longer you have that mechanical ventilation going on, the longer the risk there is of developing Bpd. Not only is it the actual mechanical ventilation and the length of that, but how much oxygen you require to be able to, or how much in levels and how long you use it. The longer you use oxygen, there is something called oxygen stress. The higher your oxygen, the amount of oxygen you're using, it actually produces something called oxygen radicals, which are essentially basically molecules that are damaging to other cells. And the older babies, and obviously we have them as adults, have these scavengers, have these proteins, if you will, these cells that when they see a radical, they kind of buffer. They're able to blanket that so it doesn't cause any damage. But for preemie babies, they don't really have that ability very well. And so they once they see these radicals, they're in free reign. They have a party and they damage different cells. And one of the nerve cells or some of the cells that get really affected with this is the eye. And this is why babies that are born very premature, that require oxygen, especially high levels of oxygen or oxygen for a long time, develop retinopathy of prematurity because of that damage that happens to the cell. We won't really touch so much on, we won't actually touch on ROP right now, but that's another topic to discuss. I'm going to stop right there for a second because I really I've got lots of people coming in. I see there's Meg. Oh, it's Meg. Yes. Hello, Megan. How are you? We have Miss Elena and Katie. Hello. And I actually have one of my colleagues, Joanna. Hello. Thank you for joining and watching. In a little bit, we're going to stop to be able to ask some. I want you guys to join if you want to ask some questions live or through the comments. So let me get through one more topic. As we're continuing with this, what are the risk factors? Who actually gets this bronchopulmonary dysplasia? You also have intrauterine growth retardation, or IUGR. Why there's that association? That's still being studied. It's kind of interesting that when you're born with IUGR, you're not just small. There is a genetic change that happens with a constant decrease of perfusion. So if you have the placenta not really being able to give you the perfusion with the proteins and all the molecules that go through pregnancy, then this is something called epigenetics. What it does is that it actually turns on and off certain genes to be able to survive. And those changes that happen in the DNA actually last through life. IUGR has been associated with obesity, associated with diabetes down the road. Heart disease as well. So it isn't just right at birth. It really does change your genetics down the road. But more than down the road, it changes the genetics of survival as a premature baby. And so you're born IUGR and you're premature. It's essentially a double whammy for the lungs. And so that does affect the degree and the severity, eventually leading to bronchopulmonary dysplasia. And one last thing is genetics. We don't know enough about this just yet, but there's ongoing studies trying to figure out what is it about. There's two babies that are born at 25 weeks. They get exactly the same ventilation. They're on the same oxygen. They've been intubated for the same 1 month. One baby goes home without any oxygen. The other baby has to remains intubated and has to have a tracheostomy. What is it about these two different scenarios that are very different? And that's where there may be something called polymorphisms, or small changes in the genes that not necessarily cause mutations that are obvious that you can see it, but it makes certain babies more susceptible to not being able to remodel appropriately the lungs, and other babies that have the right gene combination, if you will, are able to remodel the lung appropriately enough to be able to survive and not necessarily need oxygen or long-term use of mechanical ventilation. So that's pretty cool. And again, it's an ongoing study trying to figure out who's at risk, who's not at risk. We talked about the different variables, but you can see that there's so many different things. And that's why I talked about Bpd being multifactorial. All right, I'm going to stop there. We got plenty of topics to talk about, but I'm going to stop and see if there's anybody who would like to join live. Go ahead. When you go in, there is a request. Go ahead and hit that request button. You can join live and ask your question, any question you want about Bpd, and I'll go ahead and answer it, and we'll make this interactive. So, anybody want to venture to hit that request, I'll have you join me. And if not, while you're thinking, why don't you go ahead and take a minute. If you really like this, please, give me some hearts there. I'm always, trying to do this to help, and educate and have fun with it. So please, share and give me some good hearts there. So I appreciate it. Thank you. All right. While some may be deciding to join live, you are more than welcome to ask questions. And again, while we are making that decision, I'm going to scroll back and see. There was a question that was asked earlier on. Hopefully I can find it. There's been lots of good comments here. Okay, so let's see. I have a question by Pregnancy Information 999 that says, can an infant or a newborn baby get lung cancer? Well, that is a really interesting question. The immediate answer would be, I have not seen or know of any cases of babies actually being born with lung cancer. Now, does this mean that if they're born preemie, if they develop BPD, if there's been a lot of damage done to the lung, could they develop lung cancer down the road? Absolutely. There is that possibility that with all that change and changeover of cells, does it put them at risk for developing lung cancer? Yes, they could. Is BPD associated with lung cancer? No. Do I know of cases of babies? I'm sure there are lung cancer, cases that are out there. I'm not as familiar with it, but it's not something we usually think of premature babies or BPD babies necessarily having a higher rate or higher risk of lung cancer. I could be wrong. I'm going to learn about it. It's a great question and a very interesting question, but to my knowledge, that is not something I'm familiar with. Okay, let's see. There was another question. Let me see down here. Ooh. Somebody else, I'm scrolling. Whoa, there is a lot of great comments here. Okay, so Katie is asking about how do you diagnose BPD. So I talked about this just briefly, I think right before you joined, but there are different definitions, and essentially is having oxygen at 28 days or at 36 weeks. You have mild, moderate, or severe. Mild is you had it at 28 days, but you no longer have it. Moderate is you have it, but less than 30% FiO2 and on no certain device. And severe is you have 30% or higher FiO2, or you're on a device or you're on a device that receives positive pressure. Not necessarily nasal cannula 1 liter, but on positive pressure. All right. Hello, NICU Baby Club. Hello. Josh has a question there. What are the qualifications for starting dexamethasone, and when would you typically begin treatment? Josh, that's a great question. I am going to get to the treatment, and I'm going to answer that question when we get to the treatment section, because that is a really important question. Okay, so hang in there. Let's see. Hello, Miss Jolie. Thank you for joining. Do you see a difference in BPD diagnosis and/or a difference in lungs between babies whose mom received the steroid shots before delivery versus the ones who didn't? Oh, that is a great question. So why don't we get to that? That's a great question. So that kind of leads us to the next section. So that really, I didn't plan that. Thank you, Miss Jolie. So yes, before, and we talked a little bit about this when I started the Instagram live, before we had antenatal steroids. That's what Miss Jolie's talking about, the steroids that moms get before the baby's delivered. It's not so much that the steroids itself cause a decrease in, like I mentioned before, inflammation or changeover. It's just that we know that bronchopulmonary dysplasia is tightly attached to premature babies. The more premature you are, the higher the risk of developing bronchopulmonary dysplasia. So we actually know in general around the country and around the world, babies that are born less than 28 weeks gestational age are at risk 40 to 60% of getting bronchopulmonary dysplasia. The younger you are, those babies that are more in the 25, 24, 23, it could be 60 to 80, and again, the older gestational ages, 30 to 40%. So antenatal steroids can actually help to mature the lung, prepare the lung to be able to be more mature than the gestational age would indicate. So if you're born, let's say at 28 weeks, and you have not received steroids, you have got a 28-week lung, which is more susceptible to damage, which puts you at higher risk for developing BPD. What the steroids do is that it begins to kick in to be able to produce its own surfactant. It kicks in to be able to produce the nice, cellular, more cells to be able to mature, if you will, the lung. So the idea behind that is, and again, this is hypothetical because there's no real study necessarily equating a date, but hypothetically that 28-weeker that is born that received antenatal steroids, the lungs may be more akin to a 30-week preemie lung, therefore less likely to receive the same damage it would have received if it was born at 28 without antenatal steroids. So great question. That's essentially the answer. Okay, we got more people joining. Hello, Gina. Thank you for joining. Let's move on to the next topic. And like I said, I will make a break a little bit later so we can answer some of the questions you guys have. So let's talk about what are the long-term problems with developing Bpd. And then again, we will talk about how do we treat it in patient. But one of the things that happens is that Bpd doesn't end in the NICU. You've done your treatment, you've done your management, you may even go home on room air, and it's a huge blessing if you've been on if you've had Bpd to go home on straight up room air is amazing. However, you are still at risk for developing long-term problems. One of the most common long-term problems that are seen in adults, grown-up, teenagers, and adults is actually asthma-like symptoms. And this is not necessarily asthma, but it's a sort of a combination of something called reactive airway disease or asthma, as we see this in adults and children. What is that? Essentially, if you have two babies and a baby who had Bpd and a baby who didn't, and now they're teenagers, and they get a cold, the teenager who was not exposed, did not develop Bpd, would essentially have your typical symptoms of the cold. However, the teenager who had bronchopulmonary dysplasia, even though it may have gone out without any oxygen, will actually hyperreact. Their bronchioles will actually close off, the cold may be stronger, they may be needing oxygen, and the cells basically release a ton of messages to the body saying, oh, I've got a bad cold, we need to act now. And so you get a little bit of that same hyperreactivity that happened when a baby was in the NICU. And this is because the lung actually has memory cells. It's very interesting from a cellular pathological standpoint. A baby who has been exposed to oxygen and who developed some damage and was intubated and so on and so forth, the cells actually develop memory. They remember how they had to react to be able to survive. And this is a survival mechanism. They're basically saying, if I get another virus and I have to do I have to go through what I just went through, now I know how to beat it, and so I'm gonna do the same thing. Except that again, the body doesn't regulate that very well. So you may be a teenager, you get a regular cold. Normally that shouldn't require a lot of support, if you will. But that lung says, oh no, something bad's happening again, and it throws the kitchen sink at the lung. And the teenagers can get sick. And again, usually it's not anything severe. It may require, though, hospitalization. We do know that it is greater for babies to develop Bpd, especially within the first 2 years after discharge. There is higher frequency of babies returning to the PICU, to the intensive care unit, or to the floor, to general pediatric floor, because they're needing some support, whether it's oxygen or sometimes in severe cases of severe Bpd, they may need to be re-intubated, or if they have a tracheostomy, they may require higher support to be able to help them through that event until the lung can calm down and they're able to return back home. So there are these memory cells, which is pretty interesting, but again, it's a mechanism to be able to get them to react how they did back in the days. So that is one of the things that we do see. The other things, well, actually, let's talk about the next topic. Actually, let me jump to. I'm gonna skip that one because I think we already answered that on one of the questions. So the other thing is, well, how can we prevent? How can we minimize the risk of bronchopulmonary dysplasia? As I mentioned, if your baby is born premature, there is a risk already. Obviously the best prevention would be not to be born premature, and that's why the OBs, the MFM doctors do the best that they can, using magnesium, obviously with antenatal steroids to kind of get your lungs to grow, so on and so forth, to try and prevent you from being born preemie. However, if you are born preemie, what can we do? One of the things I already mentioned, being a risk, is the longer you have a breathing tube in place, the longer or the higher the risk of developing Bpd. So this is where one of the most important interventions you can do is take that breathing tube out as soon as possible. You want to do non-invasive ventilation. That means either nasal CPAP, NIPPV, CPAP with a RAM cannula, however it is, or Rapotherm, all these different methods. But essentially what you want to do is minimize the risk that you're going to be needing an actual breathing tube. The longer you stay without a breathing tube, the better the chance that the babies will actually be of not getting Bpd. This is why sometimes we play a little bit of, and some of the folks that are on have experienced that with me in the hospital, where we basically say, look, we have to try taking the breathing tube out. Your baby's at a good spot right now. We're going to take that breathing tube out to be able to, again, try and stay without that breathing tube. And sometimes you may be successful at that moment, and then unfortunately go a day or two and have to put the breathing tube back in. And a lot of families obviously see that as a step back. But keep in mind, for 2 days, you've minimized that damage that you have done to the lungs. So even that in itself is a positive. Obviously, best case, you always want to take that breathing tube out and never have it back in again. But if you have to be reintubated after some time, at least you've given the lungs some time of not getting straight, pressure into the lungs. Sometimes, unfortunately, we take the breathing tube out, it doesn't last but a few minutes, and unfortunately we have to go back in. But the goal is keep on trying, because again, you need to take that breathing tube out as quickly as possible to minimize the damage that happens to the lungs. Okay? Another thing is called permissive hypercapnia. In premature babies, permissive hypercapnia, what that is basically you allow the CO2 to come up a little bit. That does cause your pH or your acidity level to drop a little bit, but multiple studies have shown, and now it's become standard of care for premature babies, that by allowing CO2 to come up a little bit, by allowing the pH to drop a little bit, you actually minimize or you decrease the amount of damage that you are causing to the lungs. Therefore, you are decreasing the risk of Bpd. And it's not dangerous. Allowing the CO2 to rise a little bit, it was not found to be dangerous. Allowing the pH or the acidity level to drop a little was not found to be dangerous. Most times we let the pH drop to 7.20. Most times we let the CO2 go up to 65. There is a range. Your hospital may have a different number, but that's for the most part where people are fairly comfortable allowing those numbers, those extremes to go up. And that way you're able to tone down how much pressure you're giving to the lung, therefore trying to minimize that damage. Another thing that has been shown is a huge love of mine, because that's one of my areas of research, and that is caffeine. It's also a huge love of mine because I drink it, who doesn't, right? It's delicious. But caffeine actually has been shown to decrease the risk of bronchopulmonary dysplasia in a study that was done by Barbara Schmidt in 2006. It showed that if you use caffeine for premature babies, not only does it stimulate them to breathe, but it actually decreases the risk of Bpd. This may be because it stimulates higher, stronger breathing patterns, if you will. It decreases the risk of them having, frequent oxygen dips, if you will. It also has been shown to be a diuretic, and so therefore just being able to clean up or dry up the lungs a little bit may actually help to decrease bronchopulmonary dysplasia. All right, and then you know what? I'm going to take a moment right there, stop, and this is a good time to answer some questions. And so let's go ahead. Again, if you want to be on live with me, please feel free to hit that request button. I will let you join. You can ask your question live. Don't be afraid. This is a friendly environment. But if not, go ahead and add it to the comments section. All good. So let me go ahead and read some of I'm going to scroll back a little bit because some people are asking some real good questions there. Let's see. Josh, I have not forgotten your question on dexamethasone. We're going to get there. I'm scrolling. Okay, let's see. Miss Katie asks, do multiple reintubations cause more damage than just having a tube longer until we are very confident they won't fail extubation? Okay, so I talked a little bit about that, and that is a great question. I don't think we really have done, you can't really do a prospective trial or a randomized trial to be able to look at that. There's some retrospectives, but that is a good question. Is it best to just keep the tube there, let's say for a length of 20 days, or is it better to go 3 days and 2 days off, then 5 days and 1 day off? I don't know. That's a good question. Again, I haven't seen any study looking specifically at that. In my eyes, physiologically, just having that day or two off means that you are no longer pumping positive pressure. Keep in mind, anytime we are putting putting that pressure into the lungs, it is considered positive pressure. When you remove that tube, now you still have positive pressure because obviously you're doing it through CPAP, but some is coming out through the nose, through the mouth. There's definitely been a decrease in the pressure, but the baby's also now creating negative pressure. It's actually using its own negative pressure to be able to open up the lungs, and so it is both a decrease in the damage that we're doing with positive pressure. So in my eyes, and again, that's only my opinion, I would prefer to do that. Now, does that mean that you're doing 5 attempts? If you're doing 5 attempts in a 10-day period and you're failing, then you're doing something a little bit wrong. You need to wait. You do need to wait a little bit longer before you jump and just keep on doing it. At that point, there is the risk. Now you're dealing with the risk of the trauma of reintubation. Also, if this is a difficult airway and there's trauma every time you have to go in, then it's not worth it. In that case, obviously, it may be worth waiting until the next time before you attempt intubation, waiting a little bit longer. Okay, let's see. Miss Nurse Nicole asks, do providers take into consideration having to be reintubated as causing more trauma to the baby versus keeping them intubated in the setting for another day prior to going through surgery, for example? So again, Nicole, that's a great question, and similar to what Miss Katie was asking was again same idea. Is it better to just keep intubated, or is it more risky to extubate? Keep for a couple of days, especially if they're going to surgery. I think the surgery question is understandable. If you're going to surgery within a day or two, then is there a real benefit of being able to take the breathing tube out for a day and a half, 2 days? I don't know what the number is, and I think those are discussions, but those are really good discussions. Definitely as nurses, always being an advocate for your patient, as you guys always are, and that's a good discussion to have with your attending. Is the risk of having to reintubate higher than the benefit you may actually get from a couple of days not having a breathing tube, or is the risk too high? Given that this may be a difficult area, a small baby, very small baby. The other thing too, within the first 3 days, you are at higher risk. Any blood pressure changes in premature babies, especially less than 28 weeks, can cause some bleeding into the brain. And so at that point, those are a little bit higher risk, and you may elect to not extubate at that point, and then consider extubating at a better time. So that's it, my opinion though. Okay, great questions. Let's move on to the next topic. So we talked about some of the things that we can do to try and improve the outcome, and there's 2 things that are really important that I got to continue to mention, and that is adequate nutrition. We forget many times the lung needs to be able to grow, and yes, of course, we have to be very careful with how we do it, but you really want to be able to get some good protein accretion. You want to be able to get your level of protein up, because if the lung cannot grow, the lung cannot heal itself appropriately. If you're malnourished, it doesn't matter whether you're extubated, it doesn't matter any of the steroids or whatever you decide to give. If you're not getting good nutrition, especially from a protein standpoint, you're really not going to be able to grow appropriate lung. And again, I emphasize protein. One of the things that we've done for many years is we get the calories to crazy numbers, and of course these babies with bronchopulmonary dysplasia end up being very obese, and that in itself causes problems. That is not healthy. So the best thing is to really work from a protein standpoint. If you have a nutritionist in your center, you really want to make sure you talk to them, let them know how is the best and optimal way. Most places really have already standard, protocols of how to give nutrition, and that is the best way. Early on, good protein for good protein accretion is what's best for BPD. And then finally, Josh already sort of alluded to this, but dexamethasone or a glucocorticoid. So again, I mentioned this a little bit earlier on, but the dexamethasone comes from a study called the DART trial. And the idea behind dexamethasone, again, most people consider it to decrease inflammation, but it's actually more so acting as a transcription factor. What it does is that it's essentially going into your cells, into your DNA, and shutting off some of the remodeling genes. So I told you earlier on that BPD, one of the main problems is that the lung remodels inappropriately. It just doesn't create the right cell structure. It's off, it's not organized, it's trying to create these things and doesn't do it very well. So essentially it's our way of telling the lung, hey, calm down. Take a breather. We got you. Relax. Just stop making. Take some time off, if you will, and until you're better, and then you can create the right cells appropriately. That's really what the DART protocol is all about. That's really what dexamethasone is trying to do. Unfortunately, though, there is a downside to it, and this is why we always have to discuss with the families, because dexamethasone as a steroid and as a transcription factor, again, transcription factor is basically a molecule that enters the DNA and tells it to do or not do something. So because of that, and because of the fact that premature babies their brains are still developing, it has been associated with some poor neurodevelopmental outcomes. This is where you have to balance, and the NICUDoc, or our body for research, that we follow, basically they actually have a calculator. They have a way in which you can input the numbers of where the baby's at. If it's a 25-weeker, what's its gestational age, what's its weight, and what are the risks of getting bronchopulmonary dysplasia and the neurodevelopmental part. So if you have a baby that is so sick from a lung standpoint, that its oxygen levels are constantly dropping, you're getting into trouble trying to get that baby to just oxygenate well, then at that point, if you don't do an intervention, that baby is going to have a poor neurodevelopmental outcome. So the benefit of being able to do dexamethasone completely outweighs the risk of what dexamethasone does or can do to the brain. So going back, and I guess I'm answering Josh's question now, when do you qualify? This is where you have to use your criteria. Some people will start as early as 2 weeks. Some people wait until a month. Most in the places that I've worked at, most people wait a month, and then again, you use your clinical criteria, but I use, and most people actually will use the Bpd calculator. So you can actually Google Bpd Calculator and from the NICHD, and it will actually give you the criteria for you to input and gives you that risk-benefit ratio. And before you do, you talk to the families. Let them know this is not a walk in the park. This is risky. It's not like giving caffeine. It does have some risk, but that you see that the benefits of giving the steroid outweighs the risk of giving the steroid, and that conversation is back and forth. And if the family decides that they'd like to wait, you wait and you address that situation, okay? But many times we've seen the DART protocol will actually help you get your pressures down, and sometimes, and hopefully most of the times, being able to extubate, and again, that severely or greatly increases your risk, or decreases your risk of bronchopulmonary dysplasia. So when you got to do it, you got to do it, okay? All right, let's go to, we've talked about some of the therapies. Now, how about some of the controversial therapies? Some of the things that we might not expect, but we use sometimes. And this is, for example, one clear example of this is using or minimizing oral feed. So the concern for aspiration, essentially. And in some places, you actually will introduce nasal duodenal tubes. Some places use, I believe, nasal jejunal tubes to try and minimize or bypass, if you will, the gastric feeds to minimize the aspiration or microaspiration that can happen in premature babies. We know it happens. The question is, and research goes back and forth, the question is this microaspiration that we know happens, is this damaging the lungs? And in preemie babies, the constant damage that's happening, multiple times a day, day in and day out, is this what propagates? It may not be what actually leads to BPD. It doesn't seem to be what actually leads to it, but we do know because of prematurity and being intubated, all the things that give the baby BPD, could aspiration propagate, prolong, or even worsen BPD. And so there's ongoing studies to that. It's hard to say controversial because I think most people are really buying into the idea. We are actually doing a study in our center, in our hospital, looking at being able to introduce early the nasal duodenal tubes and to see what the outcomes are down the road. So we'll see what that comes out. And I know there are ongoing studies regarding that. Same thing with diuretics. Diuretics, again, difficult to put that on the controversial necessarily because it's used everywhere. We know that diuretics really help out with pulmonary edema. Does it really decrease the risk of BPD? That's the controversial part. We know it helps. It does decrease your pulmonary edema. It does help with your oxygen. Does it really make a difference outpatient? That's where there are some places like Duke Hospital and other places where they're trying to do studies to see if we give it early on prophylactically, does it actually decrease the risk or the severity of BPD? Again, not as a treatment when you actually have it, but does it actually decrease the risk? And again, ongoing studies for that. PDA closure, PDA ligation. This is a huge topic. I'm not going to get into the topic of PDA. My colleagues kind of joke all the time because I'm definitely in the no treatment for PDA camp. But there's ongoing studies. We do know that there is that physiology that maybe flooding the lungs is obviously not a good thing. We know that, and if we were to treat early or even ligate, where you do a surgical ligation to close the PDA, does that really decrease the risk of PDA? And that is still, again, controversial topic. Some studies are showing yes. Most studies are showing that the outcome really doesn't change, unfortunately, by treating the PDA early on. But it is an ongoing thing that's being studied right now. We talked about steroids and dexamethasone, the DART trial. There's another steroid called hydrocortisone, and that's being studied as well as possibly being able to decrease. It has been shown in smaller studies to be able to decrease, but it hasn't become standard care yet. There's ongoing studies. Same thing with vitamin A. So vitamin A actually really helps with the development of cells in the lung and lung tissue, and so therefore there are places where you actually give vitamin A to decrease the risk of BPD, and it has been shown to be associated with a decrease in BPD, but it's a minimal decrease, and therefore there isn't a specific. It's very expensive right now. There is in some places you can't even get it, but there is a push to be able to go that route to be able to decrease the risk of BPD. I'm going to mention a couple of things and then stop for questions. I think we may have just like five or 10 more minutes with this, so it's gone by pretty fast. All right, treatment of Mycoplasma, Urea plasma. So again, in some places, we do know that BPD is associated. Mycoplasma, Urea plasma does increase the risk of developing BPD. Some places they will prophylactically test for this bug, and if they find it, they will treat it. But that doesn't necessarily mean that treating it for sure decreases the risk. It is not standard of practice. And then finally, the oscillator or jet. Again, same idea. Premature babies, if you put them on the jet, if you put them on the oscillator, does that decrease the risk of BPD? Small studies say yes, but not enough to be able to change the standard of practice. And the risk of actually, so the relative risk is the number we use in statistics, really doesn't show. It's minimal, so it's not really statistically or clinically significant, I should say, to be able to make it standard practice for all babies to go on the oscillator or on the jet to decrease BPD. All right, I'm going to stop right there. I know we got a few more minutes. Again, I want to thank you guys for sticking around. We've had a really constant flow of people coming in and asking questions. I really love that. Thank you for all the hearts. Again, really appreciate you guys liking and hearting this. Just so people are aware, I want to do this to educate, help, and be able to converse with you guys on this very, very important topic. So thank you for joining all this time. With that, I'm going to close with the last few minutes. I think we got about 5 minutes. Let's close on questions. And again, if anybody wants to join live, don't be shy. Go ahead and hit that request button that you had when you first joined. I'm happy to have you on and request, and you can do your question live, or we can go ahead and again go through the questions that you have in the comments. So, question away. All right. Looks like we have a few questions coming in. Let's see. It says, when preemies and full-term babies are intubated, sorry, this is from NICU Baby Club. When preemies and full-term babies are intubated, can this cause swallowing and choking problems down the road? Very good question. Very good question. So not necessarily the actual intubation itself causes that's the term called dysphagia. So having problems with deglutition, with being able to pass food per se, or even just the spit sometimes. The issue is that in preemie babies who have been intubated for a long time, we take eating for granted. I mean, we all wake up, have our coffee, eat, whatever it is. And it's so easy to us to be able to put something in your mouth and immediately goes down. But it involves so many nerve cells. It involves such an activity of different muscles that need to be perfectly coordinated. They can't fire all at once. And that dysmotility, that difficulty or disarray of movement that happens, it's basically, it needs to be relearned appropriately. So if you haven't fed for a while, if you've been sick, that all goes out of the window. And you need to relearn how to eat. And this is what happens sometimes even with adults and stroke patients. They may be able to get back to life, but the eating part may last a while, and until they are able to feed appropriately. And we see that with premature babies as well. They've been intubated for a long time. If they've been really sick, if they've had to go NPO for a long time, then this put them at risk for having oropharyngeal dysphagia, not being able to coordinate well the mouth with the throat, with the actual esophagus part into the stomach. And that dysmotility takes time to be able to learn appropriately. So that's where that mostly comes from. It's not really, unless obviously there's been an actual trauma, there's been a direct damage by the tube, that's not really what causes that problem. Great question though. All right, let's see. We have a few more minutes. I want to see if anybody would like to. Again, I want to thank everybody. We saw, recently somebody, Mama Bird Henry. Thank you for joining us. The Penelope Project. Thank you again. Analia Sulin. Thank you again for joining. We got everybody. We got people from all over. Again, I have a good friend from Spain joining as well. So. Thank you again for spending this evening with me learning about Bpd. So let's see, we got a couple more minutes. I'm happy to answer any questions you guys have. I'll wait like a few seconds, and then if not, we'll just call it a night. I hope you guys have learned something. I got a DM earlier. How do I prepare while I'm waiting for a question? How do I prepare for these Instagram lives? I actually play my guitar. I don't know, you can see them down behind there, but I'm always, I just kind of, just mentally relax. These things are always a little nerve-wracking before you start. And then once you get going, they're really cool. But, so I just play my guitar and that just totally relaxes me. Let's see. Nurse Josh, Nikki Nurse Josh. He says, with regards to protein, is there a particular range you're looking for? So most places, that's a great question. We used to think that having high protein was damaging to the kidneys, and so a lot of places for a long time were holding back. but it's actually been shown now in multiple studies that you can actually go very, fairly high and be very protected. It's still, be very adequate without causing major problems to the kidneys. You do still want to follow your electrolytes. But to answer that specific question, 3.5 to 4 grams is what you're looking for to be able to have good protein accretion in premature babies. And again, same story before, or in some places they still do this, but most studies are really showing that you can start fairly quickly, because if you think about it, what you're actually getting through the placenta is about that 3 to 4 grams. And in some places before, we used to practice, once you get disconnected, you would come out, you would start your TPN, and you would start at 1 and then go up to 1.5 or 2 and then kind of slowly creep up. Well, that didn't make a whole lot of physiological sense, because obviously the babies were seeing normal levels of protein, and then you would start low, and this would cause these babies to be malnourished or require longer hospitalizations, wouldn't grow as well. And so the studies really showed that from the get-go you should start at a pretty good level. Again, every hospital is specific, so I don't want to specifically name, or give you a number for where to start. But again, most places are ending 3.5 to 4 grams per kilogram. Great question. Thank you for all those hearts. You guys have been awesome. Well, if I'm not seeing any more questions, and again, it's getting late. I know everybody wants to go back, get some rest, watch some football. Thank you so much again for joining me this evening. Had a great time, great questions, lots of people coming in and asking some good stuff. It's been a blessing. I really appreciate all those hearts. Thanks again for watching. And again, we'll do this. I'm trying to do this Instagram lives maybe 2 times a month, and I think it worked really well to be able to ask what you guys want, because I think there was a lot of engagement. So I'm gonna do that from now on. Thank you guys for everything. Really appreciate all the questions, and y'all have a wonderful evening. Okay, have a good night. Bye.